Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on JCO articles, a Phase 3 randomized intergroup trial of CHOP chemotherapy plus rituximab compared to CHOP chemotherapy plus iodine-131 tosatumumab for previously untreated follicular non-Hodgkin's lymphoma, SWOG S0016, by Oliver Press and colleagues, and yttrium-90 ibrutinib tioxetan as first-line treatment for follicular lymphoma, 30-month follow-up data from an international multi-center Phase 2 clinical trial by Christian Schultz and colleagues. My name is John Leonard, and I am the Richard T. Silver Distinguished Professor of Hematology and Medical Oncology and Associate Dean for Clinical Research at Weill Cornell Medical College and New York Presbyterian Hospital in New York, United States of America. My oncologic specialty is hematologic oncology, particularly lymphoma. Follicular lymphoma accounts for approximately 25% of patients with non-Hodgkin's lymphoma and is the most common indolent subtype. As such, its initial management approach is often counterintuitive, since patients may be managed through a variety of strategies ranging from observation, antibody-based approaches, chemotherapy, all the way to allogeneic stem cell transplantation. For many years, work from several groups suggested that little progress had been made in extending overall survival in follicular lymphoma, and this situation was complicated by the long follow-up periods needed to document results with new approaches, given the long natural history of the disease. However, the FDA approval in 1997 of rituximab, the monoclonal antibody directed against the B-cell antigen CD20, led to a number of chemotherapy rituximab combinations, given either concurrently or sequentially, that have improved survival in follicular lymphoma. Now virtually all follicular lymphoma patients who require treatment receive rituximab either alone or in combination with chemotherapy. While there are a number of chemotherapy regimens that can be included in such combinations, the typical selections include CHOP, cyclophosphamide, doxorubicin, vincristine, and prednisone, or CVP, cyclophosphamide, vincristine, and prednisone, fludarabine, or more recently, bendamustine. The relative benefits of one regimen compared to another relate more to toxicity profiles and progression-free survival, and are not generally reflected in significant overall survival differences. In the last 10 to 15 years, radiolabeled monoclonal antibodies have also come onto the scene in follicular lymphoma. The CD20-directed radioimmunoconjugates iodine-131 tosatumumab and yttrium-90 ibrutinib tioxetan have received FDA approval for patients with recurrent follicular lymphoma. Data with these radioimmunotherapies generally suggests greater single-agent activity than rituximab and effectiveness in patients with rituximab refractory disease. They are generally administered over 1 to 2 weeks. The trade-off, however, is transient hematologic toxicity and what appears to be a slight increase in the rate of secondary myelodysplasia and acute myeloid leukemia relating to the radiation exposure. Hematologic side effects that overlap with chemotherapy require that exploration of combination regimens generally require sequential administration of chemotherapy followed by radioimmunotherapy. Both iodine-131 tosatumumab and yttrium-90 ibrutinib tioxetan have been explored in a series of studies, mostly Phase 2, as a component of upfront treatment in follicular lymphoma, and results have demonstrated manageable and expected toxicity with durable remissions. In the FIT study, published by Morschauser and colleagues in JCO 2008, subjects in first remission after chemotherapy-based initial treatment for follicular lymphoma were randomly assigned to observation versus consolidation with yttrium-90 ibertumumab tioxetan. Median progression-free survival was longer in the consolidation group, 36.5 versus 13.3 months. However, a minority of these patients received rituximab as part of their induction chemotherapy regimen, which is now standard, and none of them received rituximab maintenance after chemotherapy, as is now often done in practice. Therefore, the relative merits of chemotherapy radioimmunotherapy regimens versus chemotherapy rituximab regimens have remained unclear. Similarly, the potential value of a more kitchen sink approach of chemotherapy rituximab followed by radioimmunotherapy consolidation followed by rituximab maintenance is of interest but unclear. Two recent manuscripts in JCO report on attempts to move radioimmunotherapy forward in frontline therapy of follicular lymphoma. Scholes and colleagues conducted a multi-center phase 2 trial of yttrium-90 ibertumumab tioxetan as a single agent without chemotherapy approach. For perspective, it is important to note that Mark Kaminsky and colleagues reported in 2005 in the New England Journal of Medicine 2005 352 441-9 on 76 subjects receiving iodine-131 tosatumumab as frontline follicular lymphoma treatment with median progression-free survival of 6.1 years. Treatment was generally well tolerated, though high rates of human anti-mouse antibody formation against the murine antibody tosatumumab was observed in these chemo-naive group of patients. The Scholes study employed yttrium-90 ibertumumab tioxetan in the standard regimen, which includes rituximab, and a low dose of the murine antibody linked to yttrium-90. 59 subjects, median age 66, received the RIT regimen, and some patients also received rituximab consolidation. It is important to note that such a strategy requires at least near normal blood counts to be eligible for therapy, given the expected subsequent cytopenias, and therefore there is a modest patient selection bias associated with this approach. Treatment was well tolerated. Approximately half of patients achieved a complete response, and median progression-free survival was 26 months with a median follow-up of about 2.5 years. In my mind, the results with this interesting approach are somewhat disappointing. While some patients had multi-year remissions, it is difficult to argue that these results are any better than other frontline regimens reported in the literature. In fact, some would argue that they are inferior to chemoimmunotherapy approaches that are more commonly applied alone or with rituximab maintenance. However, given differences in patient populations, comparison across studies is risky. More follow-up is needed in this trial, as 2.5 years is relatively early for an upfront follicular lymphoma study. However, the findings, in my view, limit enthusiasm for the single-agent RIT strategy given the array of other options available for patients with previously untreated follicular lymphoma. Press and colleagues report a very important and anticipated U.S. intergroup Phase 3 study that randomized untreated follicular lymphoma patients to CHOP followed by iodine-131 tosatumumab versus CHOP plus concurrent rituximab. 554 patients were enrolled with median follow-up of about 5 years. This strategy was based on previous SWOG Phase 2 studies with generally similar approaches, as well as other reports suggesting promise for these regimens. 2-year overall survival was similarly outstanding in both arms at roughly 95%, and 2-year progression-free survival was also no different at about 75 to 80% in each group. 8-year overall survival was estimated to be at about 80%, also excellent. Also in this study, additional follow-up will be of interest. However, the long remissions in many patients raises the question of whether such a combined modality strategy can be curative in a subset of patients, something that researchers and patients have been looking toward for many years in follicular lymphoma. keeping in mind that these studies do not provide information on the chemoimmunotherapy, then radioimmunotherapy, then rituximab maintenance strategy, there is still room in the intensification for upfront therapy for follicular lymphoma patients that merits further study. On the other hand, other groups, such as the CALGB Alliance, have been exploring the potential value of chemotherapy-free combination biologic regimens in order to provide disease control with less toxicity. Novel agents, such as immunomodulatory drugs, novel antibodies, and kinase inhibitors have come onto the scene in follicular lymphoma and are making their way into upfront therapy. While these new options make clinical trial design more complex, it is essential that we continue to move forward with clinical trials incorporating comparative designs and long follow-up. Despite the challenges, the outlook for follicular lymphoma patients continues to improve, and radioimmunotherapy remains one of several important components of our available treatment strategies. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.